if I can ask Carl Marsh to the floor now, who's the Director of the Integration Pioneer Programme for Cheshire. Get your mic. Carl's going to talk through some of the successes and challenges along this way.
In Cheshire, because it's not the whole of Cheshire. So I've technical issues. So Anne-Marie's asked me to come and talk about what the Pioneer Programme is, the Integrated Care and Support Pioneer Programme, what that means for us in Cheshire, and start to tease out some of the issues that we are having in terms of building that platform where we can do integrated care and support at scale and pace. Now, I thought they were 1980s comedians, but apparently they're not. This is the key word when you talk to ministers and a Secretary of State. It's about doing it at scale and pace, because there are fabulous examples everywhere of where we are doing integrated care and support, but this is about really nailing that and doing that on that bigger footprint. So, I get a dongle as well. Excellent. So there are people in the audience that are actually part of our pioneer, because I'm not the pioneer, I'm just a director. They are, so I might field some of the questions to them, and I would ask that if they see anything, if I breach any conventions or talk rubbish, Rob Nolan's there thinking, I will, then please just shout out. I think I've got half an hour, Anne-Marie, is that right? Are you going to do clock signs if I start overrunning? Okay, right. I can't use this, so I'm going to do that. Okay. So, the Integrated Care and Support Programme is a national programme around helping sites deliver integrated care and support at scale and pace. It was announced last May. There are 14 sites involved. Expressions of interest were invited. There were 100 expressions of interest to be part of this programme. And that sits with what Professor Corrigan is saying around everybody is trying to do this. Everybody is struggling with it, and everybody feels they need some kind of support. 14 sites were successful. We were one of those 14 sites, Cheshire, and I'll talk about our geography in a minute. And it was launched just after Christmas. So we have only just got going. So I started as a programme director mid-January, shot off to Australia for a month. So it feels like we are just getting going. The aim of the Pioneer Programme is, and I'll read this, the aim is to make health and social care services work together to provide better support at home and earlier treatment in the community to prevent people needing emergency care in hospital or care homes. This follows on from the work we did around whole place community budgets, which was the same thing, but that came out of Eric Pickles' office. And Eric Pickles, who was quite upfront about this, talked unashamedly about it being better for less. And that's quite an important distinction. So if it's better for less, then it's about following the scope, where there's scope to make things better, but also where the money is spent. So we'll tease that out as we go along. In terms of the support framework for a pioneer, there are 14 national leaders. Now, could someone show me how just to put this into a normal slide view? Because, just so I can see my full slide, rather than the presenter notes. Sorry about this. No. It's okay. I can work from that. That's fine. Yeah. I've got some funky animation. It's just difficult. So as part of the Pioneer, there are 14 national partners that are lined up to give us some of the support. So the feeling is that the reason why we haven't done this at scale and pace is because it's really difficult, but also there may be policy barriers. So it is about sites having access to lead organisations to start to break down some of those policy barriers. There are 14 organisations. These are some of the key ones. It's a Department of Health initiative. NHS England are on point in terms of responsible for the programme, and NHS IQ, NHS Improving Quality, are on point in terms of supporting the day-to-day running of the programme. So we have a delivery support manager who helps us to kind of identify our issues and then seek support for those issues. We also have a lead director sponsor. So each one of those organisations provides a director sponsor that links with one of the 14 sites. So for us in Cheshire, our sponsor director is Jane Cummins, the chief nurse for NHS England. So we will go to Jane, and we've already outlined to Jane what it is we're trying to achieve as part of our programme. And we can go to Jane, and then she can help us get into some of these organisations. So an example of that already is that we've been working with Monitor in terms of how might you, if this is about flowing resources into prevention, about flowing resources into community care, into better self-care, self-management, how might you suspend PBR and change your reimbursement models? So Monitor have been helping us to do some of that. And a key part of that is, how do you connect the care records? So if you want to work out what something costs, you need to be able to see in terms of that individual, not just the bit of care that individual gets from health. You need to see across the service. So what does a medium risk long-term condition survivor get in terms of third sector, acute care, community care? So if you're pulling that together, you need to be able to look at the data in a kind of cohesive way across that service. Whereas at the minute, I was a health commissioner, I could tell you to the pound how much we spent on someone in terms of the acute non-elective care, but would really struggle in terms of community care, really struggle in terms of the GP. So Monitor are helping us do some of that. Also, one of the key areas that most of the sites are wrestling with is around how do you share that information. So Norman Lamb, the Minister, who is kind of responsible for this programme, has convened a work group around one of the sites, Southend, that's had quite a lot of issues around information governance that have hit the national press, and convened a workshop where national experts went on site. They came up with their findings, which they are then sharing with the rest of the pioneers, and then it's our job then to use those findings, that work, to shape how we do things, but also share that with other sites outside of the Pioneer programme. So also in terms of our support programme, there is a small support grant. This will not fund the programme yacht. It is really small. I think for last year it was 20k, and it will be similar for this year. So none of the sites are in the Pioneer programme for the money, because there isn't a lot of it to be had. There is access to international best practice. So one of the key things we found in Whole Place Community Budget is that the evidence base around integrated care and support is not compelling. So it is about shaping your own as you go along. But there is some international evidence, and this programme is helping us stitch in to some of that. We have quarterly meetings with the DH that they call stock takes, so where they bring us down to London and ask us how it is going for us. We've had one of those. We've got one of those coming up. In terms of the tailored support, NHS IQ are the change management experts. They are supporting us with how you do some of that. We have direct systems leadership support. So we were talking earlier about this being about the leadership. Where does that leadership come from? And that is organic, and it will grow and evolve. And then how might you maximise that? So we're getting dedicated support around systems leadership. We are getting support around doing your baseline assessment and your evaluation. So if this is about making a difference, and this is a 5 to 7 year programme, so that magic number about 7 years, when we did Whole Place Community Budgets, it was a 8-month-long programme, which was really too short, and was all about generating a business case. This is about making sustained change. So that 5 to 7 year programme. So if this is a programme about better for less, how do you measure that? And that's quite tricky. You know, some of the things we are trying to impact on. So if we want a system that's better coordinated and less fragmented, and it's based on outcomes, how do you measure that? So we are working with organisations. One of them is the Policy Innovation Research Unit, around how you might get into some of the measurement. Some of that is qualitative, and they've already started doing their baseline measurement by having structured interviews with key leaders, and some of it will be quantitative. So how do you measure the difference you're making? So if you want less non-elective bed days, how do you measure that? If you expect to see less people going into long-term care or going in later and staying for less, how do you measure some of that? So we are getting that kind of national support. So in terms of Cheshire, and I think this gets us into some of the real complexities for us and some of the difficulties, and starts to tease out some of the barriers. So this is our footprint. So in the army we'd call that blue line a goose egg, even though it's not a goose egg shape, and that within that sits our footprint. So what you start to see is our complexity already, because we have 6 organisations within that in terms of commissioner organisations. So we have the 2 councils, Cheshire West and Chester, and Cheshire East, and within there we have 4 CCGs. But it gets a little bit more complex, because what we have is we have 3 locality-based integrated care and support programmes. So we have the West Cheshire Way, which is Cheshire West Council and West Cheshire CCG. In the middle we have what we call Connecting Care in Central Cheshire, and that's 2 CCGs, but you'll see they sit across 2 councils. That single management team for that 2 CCGs sits across 2 councils. And then we have Caring Together in Eastern Cheshire, which sits within Cheshire East Council. So what you have when you look at that is you have Cheshire West Council, who have 2 CCGs doing things in slightly different ways. And then you have Cheshire East Council, who have 2 CCGs doing things in slightly different ways. So you can start to see the benefits when you bring this together as a pioneer footprint. Because I bet if we looked, we would have 6 carer strategies there, or 6 strategies around learning disabilities. So what we see is that you start to see the benefits of doing this on a bigger footprint. But that gives us some real challenges. Firstly, that's a footprint we've not worked on before in an integrated way. So we have our 3 localities, and what we're trying to do is it's about local delivery. So it's not about those locality programmes stopping or doing anything differently, but it's about doing that in a more cohesive way. So if one of our localities is a little bit more advanced on integrated care teams and have already surmounted some of the barriers, how do we share that with the other 2 localities so we don't recreate it again? And then there's something about the scale economies. So if we are all wrestling with sharing information, rather than 3 localities asking the same question 3 times of the centre, we can do that once as a pioneer site. And we can convene a network that we can then start to look at in that cohesive way. The response in the 3 localities might be slightly different and nuanced, but we are doing that collegiately, so we start to get those scale economies. So for us, our key issues around our provider geography, and that's why it starts to make sense to come together on this footprint, because those localities in some cases share the same providers. So rather than the providers having to do things in a different way, they are doing things collegiately. Our patient flows are complex. So in the east, we get quite a lot flowing into Greater Manchester. In the west, we have flowing into the north, but we also have Welsh patients flowing into our providers. So that's one of our challenges and barriers as well. One of our key challenges is, do we have the expertise? So if this is about doing that system reset, changing that funding paradigm so you can flow the resources to where you want them to go, that's difficult stuff. So we probably don't have the expertise on tap. And that's why being part of a larger pioneer programme gives us better access to some of that expertise and to some models where it's been done before. So one of our localities is looking at the COBIC model that Paul talked about earlier. So they're looking at that. We can also share their experience of that with the other 2 localities. And then if we are talking about Mrs. Smith, and we are talking about the care that Mrs. Smith gets, that's end to end. that's really understanding what the other sectors are doing. So what are the third sector doing? What are the voluntary sector doing in terms of Mrs. Smith? Well, I think we're getting better of that. Certainly within Cheshire we are. But 2 years ago when we first looked at it, we didn't commission them in a cohesive way. It wasn't coherent. It wasn't strategic. We had grants that we rolled over. Now we have contracts. Now we have outcomes-based contracts. So it is about understanding what Mrs. Smith gets in terms of that end-to-end service. So this gives us quite a complex governance arrangements, because what we have is 2 health and wellbeing board areas. When you look at the majority of the Pioneer programme sites, they are a unitary authority with a coterminous CCG and a DGH in the middle. And ours is a little bit more complex than that, because we have the 2 health and wellbeing board areas. And I think that's been our biggest benefit, is bringing those 2 together. So what we've done is to try and join those 2 health and wellbeing boards up, is we've got a thing called the Pioneer Panel. We've called it a panel because it was the editorial panel that were responsible for the bid, but it's now, in old money, you'd call it a programme board. So on that, we have the 2 health and wellbeing board chairs, all of the CCG chairs and accountable officers, and the directors of commissioning from the two councils. So that gives you a weighty board, and as the programme director, I'm currently the chair. That's not ideal, but you have everybody in the room. You can see the benefits straight away, because we are having conversations that we didn't have before. And the feeling is that it's helped us when we've done the Better Care Fund submissions. It's helped us align those as well. But it is still early days for us. And I guess the difficulty with it is at the minute, and this is where we're going to use our systems leadership, is it's quite difficult to get decisions made quite quickly, because there are 10 key leaders on that panel. So how do we do that in a way that makes it more responsive, but also that all partners are happy with? And then the key thing is that we have those programme boards. So our strapline is that it's a single programme, but with 3 partners. So it's about 3 localities, 1 ambition. So it's about that work still going on, the Pioneer not slowing that down, but really supporting those 3 programmes in that cohesive way. So in terms of our bid, when we did our bid, we talked about where were the key areas, where was the common framework. So I guess if you did it as a Venn diagram, you have those 6 organisations. Where they intersect would be what we call the common framework. So what are the things that we feel we want to do together around integrated care and support using the Pioneer programme? And if you look at the orange segment, that's our common framework. So it's the things that Paul was talking about earlier. It's stronger communities. It's communities doing more for themselves. So an example of that for us is we seem to have, I think this is a national thing, professionalised a lot of the things we do. So we have a kind of a monitored bin service where if you're unable to put your bin out, you can be risk assessed, have an assessment, and somebody will put your bin out. But 20 years ago, the neighbour would have put your bin out. My dad always used to put our next door neighbour's bin out. So it's about how do you put back to communities and give them the responsibility to do some of this stuff that we've professionalised. The integrated case management, that's around wrapping care around Mrs. Smith, so not treating Mrs. Smith for a COPD and separately treating Mrs. Smith for a heart failure. So how do you wrap that round? And it's about empowering those integrated care teams. So looking for the frayed carpet. So as part of the Pioneer programme, we took Norman Lamb out to one of our integrated care teams. And one of the examples, he asked the team, so we had this multidisciplinary team, so we had GPs, practice nurses, district nurses, community matrons, occupational therapists, social work assessors, social workers, Age UK in the room, are all part of this integrated care team, and the care coordinator. And Norman Lamb asked the team for an example of the difference they are making. And one of the examples one of the occupational therapists gave, which is similar to the frayed carpet, is that she went to see a lady. The lady's frail elderly, but is quite stable. But she noticed the house was cold. Now, before, she would have noted that, but wouldn't really have known what to do. But now, because she's part of a multidisciplinary team, she can talk to the care coordinator who has access to the housing association, because we know that the lady lives in housing association, can make contact with the housing association, who can then put something in place. So the handyman went round and talked to the lady about she doesn't really need to live frugally now. She can leave the heating on, and everybody knows to keep an eye on that lady. So it's how you do that case management around the individual, and not just based on the things that are that person's been labelled with in terms of COPD and heart failure. Integrated commissioning, so that's basically what I talked about earlier, is commissioning the end-to-end and not just the siloed bits of the care that somebody receives. So how might we do that? One of the biggest challenges there is, how do you connect all the interventions together? So we can look at acute episodes, we can measure them quite well, but it's much more difficult to connect that with what social care are doing to that individual and what the community services are doing to that individual. And it's only by understanding all of that that you can better assess what you actually spend on that, what it should cost, and the outcomes that you are getting as a result. And then the integrated enablers. And it is the integrated enablers that are the area that we are focusing on in year one. So they are those things that we could do on that bigger footprint to help with some of those things in the top three components that I've just talked about. So for us, that is around, if we are going to flow the resources and we are agreed that you can't do that in your current funding and contracting paradigm, how might you do some of that differently? Also, there are those real barriers around information sharing. So that's in terms of operational in the integrated care teams. How does everybody get to see the bit of the care record that they need to see, and not just their own bit? And commissioning wise, how do you pull all that together so as commissioners you can see what's happening in entirety to Mrs. Smith? And then the other one is, if you are talking about, this is a 5 to 7 year programme, you are doing that system reset. So in 7 years, it looks very different to what it does now. You will need the workforce, and that will impact on the workforce. So we are talking about doing less in acute and doing more in community. That's people's jobs in acute. So what are the workforce implications? If we are building integrated care teams, have we modelled through how many district nurses we need for that? Have we modelled through what the impact will be on nurses and geriatricians in an acute setting? So it is about doing some of that on that larger footprint with some of the support nationally that the Pioneer programme is able to give us. And then we've started to look at what that looks like. So how do we start to operationalise some of that? Now, a lot of these things are happening in those localities. So it is those enablers that will be trying to help some of that, share the learning, make it cohesive. But there is also a sense now, as we're starting to have conversations, and that the panel is meeting and getting into the swing of it, that there might be some work streams, so task and finish work streams that we might want to do. So not just focusing on the enablers. So they are starting to emerge. And one of those is people, so better self-care, better self-management. So people doing more for themselves. How might we do that? How might we flow some resources into that? We're getting direct support from Public Health England, who think they might be able to help support us on some of this. And also comms and engagement. So that's a real key one. Being just involved in a Pioneer itself is quite communications heavy in terms of requests from the centre and requests from media and also from other sites. So how do we handle that, and how do we manage that? How do we share case studies? Because one of the things we found on whole place community budgets was we started off by trying to use the data to tell the story. And then we moved into personal stories. So things like, and then we built up a suite of stories. So one of the stories we used to talk about to describe how fragmented it was an occupational therapist was telling us about. She went out to a frail elderly lady. Her husband was her main carer. He was quite organised, so he had a Lever Archer folder with a tab for each of the agencies. How many tabs do you think he had? He had 13. So he is liaising between his wife's care and 13 different agencies. What's his qualification for that? He sounds quite ordered and orderly, but not everybody is. So if it is like that, is that what we want? If it isn't, how do you start to do some of these things differently? And we saw when we went to see our integrated care team how you start to crack some of that. But there's a whole raft of enabling things that you need to do to make that happen, but also to get some traction and for it to stick as well. Okay. I think. So one of the things, as you'd expect from a programme, a national programme, we will be measured to death. And month 2, we were asked by the Health Select Committee to do a 3,000-word submission on the benefits that we had made by month 2 to patients. Now, as a pioneer site, we really struggled. Our 3 localities, we could talk to that as localities, but not as a pioneer site. But we talked to all our key leaders about, well, have we seen any benefits so far? And we have started to see benefits. We're starting to see some of them quickly, but they are not benefits to patients. And if it's a 5 to 7 year programme, my view would be that, you know, we might want a baseline, and we might want to see what hospital admissions look like today and what placements into long-term care look like. But for us, it's about what's our preparedness as a site to start doing some of this integrated health and social care across that footprint. So we asked our leaders for the Health Select Committee submission to tell us if they felt there was any benefits so far. And I was worried about doing this because I didn't think at month 2 there would be any. But we came up with about 15. So this wasn't me coming up with them. These were people that were involved in it. So these are chairs and AOs of CCGs and key leaders from our councils. And the benefits that were seen, I guess, was about bringing those 3 localities together. And you could see the benefits when we had meetings, and we've convened a comms network, and we had our first meeting, and I think it went well. But for me, the acid test was, when it was finished, they stayed in the room for an hour afterwards, swapping how they've done things, the barriers they've hit. I had to kick them out of the room in the end because somebody else needed it. They've not had that platform before to do that sharing. And you could see I chair the panel, and it gets difficult because we get into some really deep conversations that we've not had the opportunity to have across that footprint about the barriers we face, how we've done it here, and how we could spread it there. So just that getting in a room together has started to pay benefits. And I think one of our chairs feels that what it's done, it gives you credibility being in a pioneer programme, and it makes you probably a little bit, they felt it made them a little bit braver, but also what it gives you is a direct line into the centre. So when Norman Lamb comes out, he's with us for 2 hours, that's not a one-way street. That's us being able to say, these are the bits we're really stuck on. And we've also sent a deputation down to the Secretary of State to talk about the things we think are going well, but also some of the barriers that we are facing. So tangible benefits already we feel, but in terms of difference to patients, I think we know what we want those to be, but what we keep reminding ourselves is this is 5 to 7 years. We are not going to fix things overnight. That, you know, we've got the time to get this right, to get the leadership lined up, and to really have those conversations with providers and with third sector and with citizens and patients, and start to do some of that. Not that that isn't already happening in localities, but it's doing that in a more cohesive way. So that's a quick, right, I could talk for hours on that. Am I allowed to take questions?
Yeah, of course, yeah. Just gonna get mine. So have we got any questions?
You talk about this being 5 to 7 years, which is a
Yep.
long way away. That's 2 general elections away,
Yeah.
increase in turmoil, reductions in financing. What if you never get to 5 to 7 years? Have you got intermediate targets in 6 months, 12 months, 18 months, 2 years, so that even if the climate changes, you can still point to things that you've achieved?
Yeah, we have. One of the things we had to do with the bid is we had to map out our 1 to 5 years. What I would say about the bid is that the bid gets you into the programme and then you have to recast it. So we do have our direction of travel. Remember, this is based on what the 3 localities are doing. So they will have their 2 to 5 year plans. And when you look at those plans, they will all of them talk about using the Pioneer to drive some of that. When we looked at this whole place community budget, we could map out year 1 really well, and we could map out where we wanted to be at year 5 in terms of 25% less non-elective bed use by the over 65s and 15% less placements into long-term care and a better client, citizen, patient experience. But where we really struggled, and I think it's right that we struggled, was what does the middle bit look like? So it's about creating that environment to allow some of those things to happen. So if it is about stronger communities and communities doing more for themselves, you need to flow some resources into that and you need to put some emphasis into that. If it's about citizens doing more for themselves in terms of self-care, self-management, you will need to have a strategy for that and fund some of that. So the enabling is then changing the contracting and funding models to allow that to happen. And also, if it is about, if you think to get to year 5, you need to wrap care around the individuals and that you believe the disease model is now redundant, then your enablers and your task and finish groups are around supporting that integrated case management, integrated care teams.
Mayor, just to build on that, because I'm with you, and as Paula said, it's not rocket science. I could, wrap services round my needy 80-plus-year-olds, but that takes a shift in finance, because I would need, say, 30% more district nurses. If there were GPs in the room, they'd say, well, we need 10% more GPs. And then when Mrs. Jones goes off her legs at 5 o'clock on a Friday, I've got someone I can send round to assess her and get what she needs in her own home. So that also means community equipment stepping up to the plate, as well as Occy Health, etc. So I'm be interested, given the problems we have, shifting the finance into where we know it needs to be spent. How are you going to get that? Because I could deliver you 15% less A&E attendances by putting all that in place in the community, but it needs resourcing.
And I think that's the trickiest one to answer. And I kind of, my view on that is that form doesn't follow function, it follows financing. And the reason why we've got that siloed, fragmented system is because that's how we fund it. And it is about putting the money in a crisp packet, working out what it should actually cost you year of care wise to care for somebody who suffers from long-term conditions, maybe medium risk, and then funding in a different way. And your savings should be that should cost you less than you currently pay. And almost not over-stipulating what the model looks like, but creating that environment that encourages those providers to deliver it in that way, because it would be better for the patient and more cost effective. And I'd also say, in terms of integrated care teams, we're starting to deliver those, and I'll look to my colleagues who are doing some of this and are operationalising this and have got 3 and plan to deliver as a further 9. And you don't always have to make a massive investment to do some of this. it is about working in a different way. And some of it is about physical proximity, which is not easy to do. But, you know, when you go and see these integrated care teams, you can see the difference that they are making. If you do it as a scale and pace, you could see the advantage of it. And is the investment massive for that, or is it that old adage from within existing resources? Monica, could you just wait for the mic?
We've got 3 up and running, and it's, I think the big thing is changing people's mindset of not using the traditional way of providing services. So it's actually trying to use the third sector to do a bit more, so that releases the traditional services to do more, rather than thinking everybody has to do more. It's actually changing mindsets and saying, well, if they could do that bit, then that releases us the time to do the bit that we really are best placed to be providing. So our integrated teams are starting to make a difference, and we've got some really good patient stories where we're looking not just after the patient but the carer as well. And I think that's really important to get across, is the system looking at the carer. If we're going to look at the whole person, it's the person standing behind them, their family requirements as well.
So when you say better, is that a better person experience and also a cost reduction in terms of non-elective care and placements into long-term care?
For example, one patient story we've had is a gentleman who was having a bit of a disparate time, and his daughter didn't know what was going on, and she wasn't happy, he wasn't happy. So the daughter got in touch with the GP, who's asked the integrated team, went in touch with the team manager in the integrated team. She actually made contact with the daughter and said, what is the problem? Rather than actually thinking, I think I know what's right. Conversation, and it's that conversation is really important. The team manager understood what all of the issues were. She was able to do an assessment, talk to the gentleman, put an additional increase in package of care, and you could say that's an additional cost, but actually an additional package. Instead of 3 visits, it went up to 4 visits. The pharmacy identified a pharmacy who would actually coordinate the actual medication, because there was a lot of medications going in, and he was identified a key worker, so the daughter and the patient had somebody to identify. And this was a gentleman who was a revolving door patient into secondary care. So whilst it's a small example, if we can scale this kind of example up, and that's our ambition in Cheshire, isn't it, is to do more of the same.
I'm going to take 2 more questions, and then we're going to pause for coffee.
So I just wanted to ask, to what extent have providers been involved in these discussions? I'm just conscious of this move, 15% reduction in emergency care. Actually, are the savings realisable if the providers can't actually shed any of the costs associated with delivering that care currently? And, you know, some of the criticisms, I suppose, or the questions being asked about health and wellbeing boards nationally is this point that Paul's already raised about not involving your providers in your supply chain discussions.
Yeah.
And we could all just be we could be codding ourselves that we're saving money that we're not.
Yeah. So that takes us back to our map and our 3 localities, and all our locality programmes, to the same degree, I think, involve all their providers in their locality programme. So if you look at West Cheshire Way, and I've been out to speak to providers that are the providers within West Cheshire Way, they are engaged, and it is the same for the other localities. So the conversations that we're having at Pioneer level are just kind of reinforcing those conversations within those locality programs. But as soon as we start doing something on a locality footprint, then we'll be bringing the providers in. So an example of that for us is, and I'll be as quick as I can, Marie. An example for that for us is that one of the key areas, one of our key enablers is information sharing. So if you're going to do integrated case management, you need an integrated care record. Now, that is really difficult to do because the policy is quite confusing, and its cultural barriers are in there as well. So one of our locality programs has quite a strong integrated care record program, and I've already started to have conversations with GPs, which are really positive. Now, our other 2 localities are not that well advanced. So taking that West Cheshire approach, then growing a information sharing network across the 3 localities, start to share that learning, but also do those things only once. And that's then when we convene a network and start to bring in the other localities and the other providers who, by their own admission, feel they could learn from the work that we've done in West Cheshire. And then that's on that pioneer footprint when you start to bring everybody in you need into that network, which gets big and gets difficult to manage, but you get your scale economies there.
Thanks, Carl. I'm looking at the issue around, you mentioned the Eric Pickles community budgets, which extended beyond the health sector.
Yes.
You're talking about the Pioneer programme. You haven't mentioned how it links into probation, prison service, education, all the other elements that are in a community budget and ultimately all impact on health and social care. So I'd just like you to comment a bit on how that's going in terms of bringing in wider agencies than you've got currently. And secondly, at the other end of it is where the consultation is with communities, because on your slide you indicated right at the top of the slide the number of residents you're providing services to, how the consultation is going with them, families and carers.
Yeah. So remind me what the first question was. I'm rubbish with multiple questions.
You mentioned the Eric Pickles community budgets.
Yeah.
Now, the community budget is around all services into an area and the interrelationship of them. The Pioneer programme seems to deal with the health elements of that programme. I'm wondering how you're dealing with the issues around probation, links to the prison service, links to education, links to the police, and all the other budgets that go into there, because it's ultimately one big community pot of expenditure.
Yeah. I think for us, when we did the Pioneer bid, the scope was every penny of public sector money that is spent on the population. But it was agreed that the areas, if it's about better for less, and it's about following the scope where you can make the biggest difference in terms of funding and patient experience. On the left-hand side were the 2 key areas that the Pioneer panel felt 6 organisations they could make the biggest difference. I can see Rob leaning over to read those. So families with complex needs. Now, Cheshire, Western Chester and the 2 CCGs in that footprint were involved in whole-place community budgets and have done a lot of work around integrated early support, which we used to call troubled families, and is seen as something of a national exemplar. So that is around how do you wrap care around those families, and that is the probation service, the police, it's health, it's social workers, and that's an integrated case management, and that's having a rather than using the common assessment framework, developed its own family assessment framework that all those different agencies can read and write into. So you're assessing wants and sharing. So that's something that we think there is mileage in sharing across our other 2 localities that probably aren't as well advanced in terms of that piece of work. And then the other work was around the frail elderly. So those with long-term conditions, as a proxy for that, the over 85s. So, how might we improve care for those? And that involves that wider service. It is the third sector, it is the voluntary sector, it's all aspects of health, and it is social care. So they are, I guess, where we are moving to in terms of as a pioneer site.
I mean, what's really important about those 2 groups is that they're both high-cost groups, and you're doing integration for those groups rather than simply doing integration. So there's a focus, and it's a focus around a group which are both very complex and very expensive and very needed. And I think the reason that's important is that people can do integration and start to do it for everybody, and you run into the sand. That I think it's quite important to segment the population when you're doing this. And these 2, as I say, are very high-cost groups. Some places I go to and say the frail elderly is the most expensive, and they can point out the 5 young people that have been to only 200 times. because of drug dependency, da, da, da. And so, in a sense, those are the groups that if we don't crack, we go bust. And I just think, what we've done in the past is tried to do a thing like integration for everybody, and the people say, well, what about this group, what about that group, what about that group? And that's just hell. It's just impossible to do it. So doing it for high risk, high dependency groups is very difficult, but at least there's a focus.